Thank you so much. Thanks everybody for joining today. I am Dr. Tammy Dakota. I'm coming to you today from Bismarck, North Dakota. I'm an enrolled tribal member at MHA Nation and also have lineage at Turtle Mountain, Chippewa. So I am going to talk to you today about Native American culture and mental health from a pediatrics perspective and a trauma-informed perspective. Um, we certainly in Native American population need a lot more specificity in our data in terms of what exactly is happening with behavioral health trends and what are the causes and origins of those things. But what's really clear at this point and what we know are trends is that American Indian Alaska Native people report more psychological distress than the general population. And there's higher rates of mental health problems, including PTSD, suicide, violence, and substance use disorders. We've known that for a long time. Those things are obvious in our communities. And this is really pre-COVID data, and Native American population, I believe, experienced the greatest reduction in life expectancy during COVID and post-COVID. I think they're down to a life expectancy of about 64 years. Many of us who work with and know Native communities understand how devastating COVID was, particularly to their elderly population and the continued traumatic grief that they're experiencing because of that. So we can imagine that post-COVID numbers, as that data is being collected, is going to look higher. We know that the rates of violence, substance abuse, mental health problems, depression, suicide have spiked post-COVID in the general population. And I can assume that they're even higher in the Native American population. So I won't spend a lot of time on these data. I want to get into some other impacts that we know. Again, just reminding everybody about what's another contributing factor here. We now understand very well the adverse childhood events data. In national studies, we've seen repeated over and over again that roughly 64% of adults in the general population who are surveyed report at least one ACE, and 1 in 5, or about 25% of adults, report 3 or more ACEs. So ACEs are more common perhaps than we used to think they were. And according to the ACEs surveys and data, people who have 4 or more ACEs are significantly more likely, like 12 times more likely, to experience negative health outcomes later in life. There is data currently being collected, studies underway to develop a Native specific ACEs survey. And some studies have been done looking at specific Native communities and what the ACEs data looks like there. In one study in the upper Midwest, Native Americans who were surveyed reported about 78% of participants reported having at least one ACE, and 40% reported at least 2. So even in this data, although there's a small amount of it, we're already seeing that, yes, indeed, Native populations appear to have higher rates of ACEs than non-Native populations. And then, of course, minority groups are at higher risk of having exposure to ACEs than other groups of people. And statistically, we know that people who have experienced those 4 or more ACEs without intervention are way more likely to experience depression, and then engage in unhealthy behaviors like smoking, other types of substance abuse, binge drinking, and then, of course, more likely to develop chronic pulmonary lung disease or other health-related diseases. Some of you may have seen this before. This is the ACEs pyramid that shows the progression of exposure to adverse childhood events at the bottom, and then the social, emotional, and cognitive impairments that come with that, the adoption of health risk behaviors that lead to disease and social problems and early death later in life. On the right, what you see is the proposed or the hypothetical ACEs pyramid for the Native American population that adds 2 additional layers, even pre-birth. Which is the history of historical trauma among our ancestors and the epigenetic impact of that, and then the social conditions, local context. So what they're really talking about here is the historical trauma, and then the intergenerational passing on and impact of those things that that set Native American populations up for higher rates of ACEs and health-related issues later in life. So now I'm going to segue a little bit more into talking specifically about trauma and how trauma impacts our people, and particularly our pediatric population. Oftentimes when we talk about trauma, providers think about PTSD or actual diagnosable condition. And certainly that there are individuals who are exposed to trauma that end up meeting criteria for PTSD or another trauma-related disorder. But not all individuals will meet these criteria, but still will have significant impacts from trauma. So as we're thinking today about, well, what is trauma then? The definition of a trauma is really anything that overwhelms an individual's nervous system or their ability to cope, and they don't have a chance to process it out later. Those things can be traumatic. So you can imagine for the child population, although we often talk about them as being the most resilient, and in some ways they can be because they're so imaginative and creative, they're also the most vulnerable because they have the least amount of power, and the least amount of control over their situation. And without adequate caregivers and resources to establish safety for a child, then they can be really vulnerable to the impact of trauma around them. So in the field of trauma, when I'm doing an intake, I'm looking for 6 primary risk factors to assess the history of trauma in the individual. And the first one is actually looking at prenatal stress, collecting as much information as I can about what was happening with their pregnant mother while she was pregnant with that individual, and how much stress was she under. Was there violence in the relationship? Was it an unplanned pregnancy? Were there financial difficulties? Was she struggling with her own physical or mental health issues? And because chronic exposure to stress hormones is harmful to a human, it's also harmful to the developing fetus, and the stress hormones cross the placental barrier and impact the developing fetus in ways that can potentially have long-lasting effects for that child. Prenatal substance exposure is an obvious one. I think here what I want to mention is that statistically 8 out of 10 children who have been or are in the foster system have been exposed to substances. And sometimes we make the wrong assumption that if a child has prenatal exposure, they're gonna look different, right? They're gonna look like a fetal alcohol child or have some facial deformities that's gonna make it obvious. And the truth is, especially more recently, as the prenatal substance exposure is about polysubstance exposure and not just alcohol, those children look like typical children. And if, you know, in order for the facial features to be impacted, there has to be quite a bit of alcohol use at a specific period where facial features are developing. And so the majority of these children don't look any different than a typical child, but their brains function very differently. And so in the most severely impacted children, what this looks like developmentally is that if the child gets into a stable setting with adequate supports, they may begin to make adequate progress at an appropriate rate, but they're still like a step or 2 behind their same age peers. But then where we see them destabilize is at the onset of puberty, because the substance exposure to a fetus actually damages brain cells that are quiet and asleep. They're dormant until puberty, and at puberty they flourish and grow very rapidly. But if they've been damaged, that doesn't happen. And so we can see a child be fairly stable, and then that they can destabilize pretty quickly and demonstrate sometimes very severe behavioral and emotional problems at the onset of puberty. These are the kids that do well in foster care until puberty, and then they destabilized and disrupt from their home settings also. With most severe impact, what they tend to look like diagnostically is schizoaffective. Birth trauma and early hospitalization. This is the attachment literature. We understand now and have since the 50s and 60s that when there's a separation, particularly during those early formative years, at birth to age 8, the peak of the most neuroplastic time for attachment is between 1 and 3 years. So when there's a separation that occurs for any prolonged period of time, which really is just a few days or more for some children, that can really be destabilizing to the infant's nervous system and the young child's nervous system and can have long-lasting trauma. This is also the literature that changed the rules about hospital visitation for families and allowed family members to be present with children. And when that started happening later in the 60s and the 70s, what we saw statistically was that the death rates dropped drastically and children got healthier faster. And so we began to understand more than the impact of having caregivers present when children are ill, and how that really optimizes and promotes their survival and their well-being. Abuse, of course, is a risk factor. We sometimes make the assumption that physical abuse is much worse than neglect. It's not always about what is done. It's often about what is not done for children. And neglect, in fact, can sometimes be even more detrimental and have long-lasting effects. In a way that even abuse doesn't. So, and then of course, traumatic incidences, which are the things we normally think about when we think about trauma, violence, disasters, and separations and multiple placements, I think is important to consider because every time we move a child in a foster situation, we create another hardship and potentially another harmful trauma. It's not uncommon for me to see, I just saw a child not too long ago. He was 8 and he had been in the foster care system for 3 months. He had some challenging behaviors. He had already had 8 foster placements in a 3-month period. So in addition to all of the things that happened to him that caused him to get into foster care, he had another additional 8 traumatic incidences just within the foster system. And I understand that foster care workers are doing the best that we can, but as a national system, we have to do better than that. So there are 2 non-diagnostic terms that we use in the field of trauma that are really important for everybody to understand. Complex developmental trauma or something along those lines is being considered for the next DSM version. I hope that we see it in there. Basically, what complex developmental trauma refers to is when a child has multiple incidents of trauma during their childhood that lead to global brain impact and broad range of developmental deficits. So as that brain is developing, the environment is shaping how the brain builds. And each time there is a neglect or a traumatic experience that happens, the brain builds in ways that create disruptions in how they're responding accurately or inaccurately to their environment. And so if we think about these multiple periods of time where the brain is developing and there's negative impact to different areas of the brain, because the brain develops sort of from the bottom up and different regions are developing the most or have the most sensitivity at certain times, then what complex developmental trauma is having deficits in all developmental capacities and global negative impact to the brain. And so these are kids that need a broad range of treatments and not just psychological impact or psychological intervention. They need multiple developmental supports. So what are the developmental areas that they need supports in? Well, they need relational interventions, educational supports, speech therapy, occupational therapy is an absolute must for these children. So all of those developmental emotional regulation, cognitive interventions and supports, all of those developmental needs need to be supported for the brain to recover and for the child to have the best chance at optimal development through the rest of their childhood and lifespan. Statistically, 90% of children who have trauma exposure have sensory problems. So we see a high rate of sensory processing disorders among these children. And sensory processing, if you If you do not understand what sensory processing problems look like, 100% of the time, adult makes the mistake of thinking that it's naughty behavior. And so when I see a child that has exposure to trauma, or I even suspect exposure to trauma, 100% of the time, I'm making a referral for an occupational therapy, and I want a full evaluation, not just looking at sensory seeking and sensory rejecting. I want a full evaluation that's looking at stuck reflexes and tongue thrusts and these kinds of things. And then a determination in terms of what's the best intervention for this to occur. We want sensory diets in all of the child's primary environments, so home and school, daycare primarily, so that the brain is being stimulated in ways that can help it recover from these sensory difficulties. The other term is relational trauma, and that really refers to when a child has been harmed by a caregiver or somebody that is close to them, or that they should be expected to keep them safe. And this impairs the child's ability to feel safe in the context of relationships. So we're all born with kind of an orienting response to whenever we feel frightened, and we're all born with a nervous system that the first stop in the stress response system, and the healthiest response is to go find our safe person. So the example that I like to use is one of my children, who's now 15. When he was a toddler, he just had a really sensitive startle response to noise. So somebody would drop something in the house, and his initial response would be to startle, kind of drastically. And he would just automatically run and find me and grab onto my leg and go, "My mommy." And then, sorry, my alarm's going off here. My apologies. So what he was doing is there was a stress response in his nervous system that triggered his connection response, his response that said, "You're in trouble, go find your safe person." And he found me, and because I was his concept and his experience of safety, his nervous system regulated within a few seconds, and then he was back to his normal self, and he would toddle off, no trauma. What happens with these children is their safe person is also the person who is causing them harm. And so the nervous system gets this really dichotomous and confused message of where one part of the body is saying, "Go to your safe person," and the other part of the body is saying, "Get away. People are not safe." And so in what this looks like in relationships, even with young children, is you get this real push-pull, where it's like the child is seeking or demanding help, and then once you try to reach to them for help, they'll physically push you away, or they'll reject you in some way and push that help away. These individuals become older children and adults who want relationships, desire connection, but their nervous system cannot regulate and feel safe in relationships. And in fact, the trauma trigger is vulnerability in relationships. So as they begin to feel close to somebody, particularly in romantic relationships, in relationships where somebody has authority, like a teacher or a parent, their nervous system begins to send threat signals. And like most humans, what we do when we feel anxious internally is we try to manage that anxiety by externally controlling our environment. And so they try to manage their internal threat response and anxiety by externally controlling the other person. And without intervention, this can escalate to the point where this becomes manipulative and lying and abusive. It looks a lot like borderline personality disorder. In the worst cases, it starts out as reactive attachment disorder, and then really most of the time kind of evolves into BPD without intervention. All right, so this is just a table that shows kind of the 4 basic brain regions. And again, the brain develops primarily from the bottom up. All of these 4 regions overlap, but what you're seeing here in the critical period in that center column is the period of time where there's the most neuroplasticity for that part of the brain to develop. And you can see that our critical periods last for these 4 brain areas. The most neuroplasticity kind of ends about age 6. There's still a lot of neuroplasticity in the brain. Particularly now we understand there's another spike during that puberty time, where there's a lot of neuroplasticity and the ability to grow and make changes in the brain. So even though we may see a ton of impairment in some of these children, there is a lot of capacity for the brain to recover and those areas of the brain to be fixed with the appropriate interventions. So the interventions are really kind of basic. What the brain needs for proper development is rhythmic pattern input and engaged, attuned caregiving, where the caregiver understands what the child's cues are and responds to those cues. That is necessary at every level of development, but as the child ages, those techniques just get more complex. And so for a newborn infant, even in utero, rhythmic pattern input is the heartbeat. It's rocking, it's patting, it's humming, it's singing, it's this face-to-face cooing stuff that we do with children. And we know through research that depressed moms have children with delayed speech because even though they're doing a good job of keeping their child safe and taking care of their physical needs, when and if they engage their children, they have flat affect and that impairs speech. So if we imagine a parent, an unskilled parent, a parent who's suffering from mental illness or substance abuse, that's not picking up their child a lot, that's not soothing and providing these sort of sensory experience for their child, then the brain's not getting the stimulation it needs to develop properly. And because this is a bottom-up development, it's sequential. So the upper parts of the brain cannot properly function unless the lower parts of the brain have properly developed. And so even if we're seeing a child who's 14, 15, 16, if we have symptoms that are associated with brainstem impairment or diencephalon impairment, or these area of the brains that have the most neuroplasticity much earlier in childhood, we're gonna implement rhythmic, patterned, attuned caregiving on a regular basis in all of the child's primary environments in order to stimulate the brain enough for recovery to occur. Remember, neuroplasticity really is like this period of time where they can just be passively learning. A child just needs to be present in that environment and they just absorb it and the brain develops. Once we're beyond the neuroplastic time, development can still occur, but there needs to be more repetition. There needs to be more intentional, repetitive activity to stimulate that brain properly. Some studies have shown, like when we're reshaping behavior, when we're teaching, it's about 400 repetitions for a new behavior to develop outside of the neuroplastic time. But when joy is present. So when the child's playing, when there's playfulness, happiness, sort of laughter, it's 12 repetitions. So we're beginning to understand what's the neuroscience behind that. Well, the experience of joy disarms the amygdala. And when the amygdala is calm, the upstairs brain, the learning parts of the brain is optimized. When the amygdala is not calm, when it's really on fire and there's a lot of threat signals, then all bets are off for learning. So, and I'll circle back to that towards the end of the presentation, because that science is the basis of how we approach behavioral changes and correcting behavior in children. So the attachment system I want to emphasize in this presentation because as we're working with children, it's so necessary to be coaching parents, whether the caregivers are their natural parents or foster parents or some other type of caregiver. It's so important for them to understand the importance of that attuned caregiving, even if a child is no longer an infant, because we have to go back and repair that attachment brain, which is part of the limbic system. And this is part of the brain. I mean, the attachment system is really a brain mechanism that develops to help that child feel safe. It helps them learn how to self-regulate, right? So the pattern is First, the caregiver regulates the child because infants aren't born with the ability to calm themselves. So this kind of, I guess it's old school now business about you just let your child cry, they'll learn how to soothe themselves is not true. They'll learn how to stop crying because they'll learn that help is not available, and the social connection system in the nervous system will shut down, and they'll have trouble seeking help in the future or knowing that help is available. There is a time later as the child will learn to self-soothe, but that's not in early infancy. It's necessary for the caregiver to soothe the child, and it's necessary for the caregiver to understand what the child's cries mean and respond to those needs. So attunement looks like a child cries because they have a dirty diaper, and the caregiver understands that the cry is about the soiled diaper and they change the diaper. So they're meeting the need. Disattunement looks like, we've probably all seen this. A caregiver has a young child that is crying because that child is sleepy, they're tired, and they don't understand what that cry means. And so rather than soothing and comforting the child and putting them to sleep, they might play with and tickle the child. And if you've seen this sort of disattunement, although the parent is providing by all definitions, like an appropriate parenting response and a safe parenting response, it's disattuned, and it actually doesn't serve to soothe the child. It serves to further agitate the child. So again, that nervous system, rather than finding safety and regulation, is continuing to put out a threat signal. The other thing that's necessary for attachment brain to develop is co-regulation, where the parent is able to regulate themselves enough for the child to cue off of their nervous system. We've probably, all of us with children who have taken care of children, have the experience of what it feels like when ourselves or maybe a spouse comes home and we're just really dysregulated. And then the whole house disrupts. All the kids are dysregulated because children are wired to cue off of our nervous systems. And so they'll feel what we feel. And so if there's chronic dysregulation in a parent's nervous system, then the children are going to have a really difficult time feeling self-regulated and learning self-regulation in their own nervous system. So the pattern is they must first be regulated in order to learn to regulate themselves, so that they can empathize and understand their own emotions and other people's emotions, and then regulate somebody else. So again, another foundation of trauma-informed care is teaching the skills of self-regulation and sort of reconnecting that neurology from brain to body that helps regulate the body. When the nervous system is actually more wired from bottom up, from body to brain, that's when the amygdala and the nervous system just hijack the brain, and we get some pretty out of control responses that way. So this is also important part of the brain because it helps us make sense of life. It helps us feel like life has a purpose, like we can make meaningful connections with others. It's really the stuff of life. And so how we work with this in the therapy office is to be observing the interaction between the child and the parent, to be watching for cues that indicate there is a healthy attachment present, that when the child is upset, they seek out their caregiver, actively seek them out. The caregiver makes attempts to soothe the child, and the child becomes soothed. They don't continue to cry. When I don't see that between a child and a caregiver, I will coach it and in a way that helps the parent understand the importance of those things, but also feel successful in the office, right? So I might be saying, can I show you something? And I might demonstrate it, or I might give them verbal instructions, hold the baby. Sometimes these parents will hold the baby facing out, turn the baby towards you. I might instruct them in like a regulation activity. Let's do some breathing together, calm yourself first. Now hold your baby close to you. Pat, soothe your baby, rhythmic pattern input. They'll have the experience in the office of the baby calming, and then we go, nice job, look at what you did, and they have an experience of success. And so we want to reinforce that pattern. In somewhere in transferring these slides, I lost the actual numbers of what this pie chart looks like. But you can sort of see visually here, statistically, when we're looking at the general population, we have a little over 50, roughly maybe 60% of the population that's considered securely attached. And then there's this sort of 25% or so of people, 30% of people that are insecurely attached, but it's not very severe. So they're still functioning well, but maybe they have trouble like connecting with emotions. They're kind of avoidant. Maybe they're kind of anxious, but they're generally functioning well. These are people who might struggle with some depression, anxiety, substance issues, relational issues, but nothing real severe. And the disorganized population is the much more severe portion of this. And these are the people who have that severe impact to the attachment brain and cannot self-regulate, understand self, understand others, and normally are not functioning well in all areas of life. And so that's somewhere around like 8% or less of the general population. But when we look at the foster adopt population, this is what the pie chart looks like. It is alarming the percentage of children within this population that have that very severe disorganized attachment style. This is like severe attachment brain impairment. And these kids are going to have major behavioral and emotional struggles and probably substance abuse. And the trajectory for these kids is over half of them end up in the judicial system. And so we don't have to, we can make some pretty well-educated guesses, even when we don't have a lot of history of individuals. If we know they've been in the foster adopt system, we can make some pretty well guesses that they probably have complex trauma, right? 80% of children have significant trauma. 9 out of 10 of these children are going to have really obvious sensory processing difficulties, and more than 75% of them are in this disorganized population. That's really alarming. I've always wondered about, this is like a little less than 5% of the population is securely attached. I've always wondered about who are those kids, and if I had to guess on who are those securely attached children in the foster adopt population, it's children who have had kinship placements. So I think it's important to make this point about Indian boarding school. People ask me often about, of all of the genocidal government policies and the trauma and historical trauma that Native people have suffered, is there one that has been most detrimental? And in my opinion, absolutely, absolutely, it is the boarding school era. And the reason for that is because Indian children had multiple attachments. They had attachment to their kinship, right? Their extended family system, which was these very close relationships where people had specific roles about how to interact with them, but they also had attachment to their culture and their universe, and the animals and the language and the ceremonies, because of the way that they lived interconnectedly. These were also attachments, and particularly I think that Native people at this time had an attachment to their location, to their land, because the land contains the culture, it contains the life that sustains us, the medicines, the energy from the ceremonies exists long after the ceremony is done, and it contains the ancestors. And so that attachment to place was really significant. And when the children were taken from their communities and placed in boarding school, 100% of their attachments were broken. And it's been very clear for a long time in the literature that the single best buffer, the thing that prevents long-lasting detrimental impact of trauma, is connection. Even just one safe connection. When scientists have looked at groups of children who have like one safe, stable connection, a neighbor, a teacher, doesn't even have to be a family member, and compared them to children who come from homes that are physically safe, there's no violence, there's no chaos, but the family is not connected. They're not, they just don't do relationships. When they look at the longitudinal data between those kids, the kids from the traumatic backgrounds with the one connection do better in the long term than the children from the safer environment. So, you know, and that sort of data has been looked at and repeated in the literature over and over and over. And so the importance of attachment here, and we look at these kids who had these multiple attachments that were just removed abruptly. So now they are completely vulnerable to stress and trauma. And then they were placed in institutions that used really harsh corporal punishment, had an absence of any real ability to form selective attachments. Even siblings were separated from each other and often not allowed to interact, and then mistreated in these really terrible ways. So the children that survived, many of these children didn't even survive these situations, but the ones that survived, I can only imagine the extent of their complex developmental trauma, and their inability to feel safe in their bodies, to feel safe in the world, to understand themselves, to understand relationships. And as we tend to do as humans, we repeat the patterns that are familiar to us. So we do what was done to us. And this really kind of began this history of child maltreatment in our communities. And many of these children, I think, also came out of these institutions and were able to have families and not abuse their children. They were able to keep their children safe, but what they weren't able to do because of the attachment impairment is they weren't able to develop secure attachments with their children. So even in the absence of abuse, insecure attachments were developing, because their own lack of ability to feel safe in their own bodies and their own lack of ability to connect with their own emotions and understand the emotions of their children. And so 85% of the time, even when abuse is not present, the attachment style of the child will match the attachment style of the parent. So there's that inner generational pattern of difficulty with parenting and attachment and relationships that gets passed on generation after generation without actual target intervention and coaching caregivers on how to establish secure connection with their children. What are the behaviors necessary? And then what do caregivers need to do for themselves to feel regulated enough to do that? So this business about, you know, that I'm sure so many of us has heard a lot, like that was hundreds of years ago, like move on, get over it. Why do Native people keep bringing this up? That's just literally not how the nervous system works. And we now understand in epigenetics that trauma is inherited. It's passed on in the DNA, and the sensory memory and most of what triggers trauma, the trauma trigger, is actually sensory information. And so it's a smell, it's a color, it's a season, it's a temperature, you know, it's a tone of voice. That sort of sensory information is what gets passed on, and can accumulate until it is treated. So we really have to think about, you know, what's done to the individual needs to be treated at the individual level, but what's done to an entire community requires community-based treatment. So both of those are necessary as we move forward with our Native patients. We're all familiar with what the human brain looks like. The point I want to make on this slide is just the concept that many of you have heard about upstairs versus downstairs brain. That when a child is exposed to a lot of trauma, so trauma can be chaos in the home. We don't actually have to physically harm a child to create a traumatized brain. If there is not a pattern and a routine, then the nervous system doesn't know what to expect. And humans, creatures, animals, love patterns and routines. We are creatures of habit because when we know what is happening next, when we know what's familiar with us, we know how to predict the next thing. And so if there is no routine in the home, the nervous system doesn't know how to feel safe. And so that can also lead to a brain that is overdeveloped in terms of the survival brain. So the upstairs brain is the thinking, self-control, creative, personality, playful part of the brain that does the most logical, rational part of our thinking as well. And the downstairs part of the brain is generally thought of as the survival-based brain. And so what happens in children who have environments that are chronically stressful is that downstairs survival brain gets overbuilt. And if there is also at the same time neglect present, there's a lack of stimulation for that upstairs brain to develop, the upstairs brain gets underdeveloped. So we get like this upside down pattern of brain development with these kids. When that is the case, then that overbuilding of the stress response and the underbuilding of the cortex leads to children that have the most primitive, immature, and violent responses. I used to do consulting for North Dakota State Penitentiary, and like the majority of the individuals that I was working with in the sex offender population, that was these fellas, and they had, almost all of them, I think maybe 100% or close to 100% of them, had really traumatic childhoods and had not received really adequate intervention throughout their childhood. It had not been recognized and supported adequately for them to recover. So again, sort of thinking about where the brain and the nervous system is at and that upstairs, downstairs brain, in order for the individual children and adults to access the upstairs part of our brain, the part of the brain that we need to function in life, to learn new things, to manage our relationships, to do well at work, to perform in school, the body has to be in a state of calmness. And we've all experienced a time where something scared us, or we were in a panic, or we're just under a lot of stress and we can't access our memory. We can't remember what we studied last night. We can't remember our phone number. We can't remember somebody's name because the parts of the brain that contain that information go offline. If we were to take a picture of the brain, we would just see it go black. And the more agitated we get, the further into the downstairs brain we go and the less access we have to the upstairs brain. So for learning to occur, for healing to happen, first and foremost, we have to work on calming. We've got to work on regulation with the child or between child and caregiver. So this is a slide that illustrates this upstairs, downstairs idea. It comes from a book called The Whole Brain Child by Dr. Segal. And all of the trauma-informed literature is based on this science that's illustrated here, that being trauma-informed means understanding what it looks like when a person is in their upstairs brain versus their downstairs brain. What do trauma behaviors look like? And how do we know when somebody's beginning to go downstairs? What are the cues in a child that indicate that they're headed downstairs? So where we want to provide the intervention is when we see those skills. If we wait till a child is fully in the downstairs brain, we're going to see total shutdown or a rage reaction. And then it's just a matter of like waiting it out and helping, regulating yourself so you can regulate the child and helping them get back upstairs in the brain. Because no learning can occur. We need to stop talking. We need to stop instructing. And we just need to go into calming phase until they're back in the upstairs brain. Then we can circle back to the behavior or the issue and we can deal with it. That is a minimum of a 30-minute intervention and sometimes hours. I've worked with a child before who, when he had a downstairs brain reaction, it was 3 hours before he was anywhere close to the upstairs brain. And the more time that we spend in that kind of stress response with a child, the more damage that's done. So the goal is just to prevent them from ever getting there. But if they get there, to get them turned around and headed back upstairs as soon as possible. And so we're noticing what those cues are in terms of, the areas that we're looking for is connection. We'll see some sort of disconnection. They either shut down or they become oppositional, kind of attacking. So the relationship connection disrupts. We'll see lack of control of the body. There's either no movement or there's too much movement. And we'll see inability to communicate, or inability to regulate emotion, both of those things. So probably 4. So they're either yelling and screaming and irrational, or they're not able to really communicate what their needs are, what's going on with them. And then you see the emotions kind of go flat. Again, the sort of freeze response, or they're emoting and projecting emotion in really big ways. And so we're looking for those cues, those 4 cues, to indicate what type, where they are in their brain. And everybody's cues fall into those 4 areas, but how they manifest, what they look like, is a little bit different. So my husband and I did foster care for about a decade, and we had one little boy, for instance, that his very first cue when he was getting stressed and starting to head downstairs is the palm of the hand would go to the forehead, and he would start kind of rubbing his forehead. And then pretty soon the fingers would go into the hair, and he'd start pulling on the hair. And if we didn't catch it and get it turned around, he would very soon be into a full rage response, and he would be self-harming and ripping hair out, and it was very severe. And so with other children, the cues are very different. So that's what you're looking for as you get to know a child. So again, the trauma-informed science is based on these 3 pillars in any program. So there's different language depending on the style or the program that's being implemented, but they're all based in the same science and on these 3 pillars. So the central pillar is connection, that first and foremost, before we do anything else, we have learned how to make a connection with the child in a way that helps them feel safe. So we're aware of ourselves, we're regulated in our nervous system, and we're understanding that they may have that brain that tells them that relationships are harmful and scary. And so we're going to go above and beyond to make sure that our tone is soft, that our face is inviting and smiling and soft, that we're not making any big or quick movements that could frighten them. And so this is the central pillar. Whatever else we're doing, we're staying in this connection space. In behavioral modification, we call it connecting while correcting. And as soon as the connection disrupts, we stop correcting, we reestablish the connection before we move on. Managing emotions is about teaching self-regulation through mindfulness, through programs like zones of regulation in school system, helping them reconnect mind to body, notice what it feels like in the body. With children with sensory issues, they have trouble feeling into the body. They're either feeling too much or they're often feeling too little. So we're helping that part of the brain called the insula develop the sensitivity it needs to be able to feel sensations so that they can regulate themselves. We see lots of issues with eating and enuresis and copresis with these kids too, because of that insula deficiency. And then safety. And safety is about physical safety in the physical environment, but it even more so is about what we call felt safety. Can I feel safe in my body? And how do I know when I feel safe versus when I don't feel safe? One of the things I love about the trauma informed literature and the neuroscience is that it really validates Indigenous practices as some of the best ways of healing, because again, we're going back to the stimulation that the brain and the nervous system need for it to reestablish a healthy rhythm for the chaos that trauma creates to settle down, so that the brain can rebuild and redevelop after trauma has occurred. And those things are that connections, right? The relationship basis, more connections are better than fewer connections, and the rhythmic pattern to input. And in all tribes that I'm familiar with in the US, their culture is based on these concepts. It's the foundation of who they are and how they interact and how they live life, is with these rhythmic patterns, sensory inputs of movement, noise, even the flow to their day in their clanships, how they connect with their universe, with one another, and so on and so forth. So that is the end of my presentation. Let me stop slide share here, and then I can open it up to any questions.
Again, feel free to unmute yourself or utilize the chat feature. Hello, I just wanted to thank you, Tammy. That was tremendous. That was so much great information. I worked in organ donation for a long time, and our donor family advocates in the presence of donation and death and everything always worked a lot on regulating the family as much as they could when they were going through the process. Um, uh, so the critical access hospital that I work at, is there anything you'd recommend in an ER setting for caregivers? Obviously, we don't see a ton of peds, but when we do see peds, any kind of
Yeah. So in
wisdom?
an emergency setting, and I think the docs and the nurses do a really good job of like maintaining their cool and, but so that's important to sort of have at least one caregiver making that connection with the child. It might be holding their hand, it might be providing some reassurance, but sort of that warm, nurturing presence. If they don't have a family person present, also helping their family member who might be panicking about what's going on regulate. And then choice and voice, choice and voice, choice and voice. I cannot emphasize that enough, whether it be in an exam room or in the ER, that we're always, because when somebody has trauma, their choice and their voice was taken away. And the one thing that will trigger that stress response, like nothing else in a person with trauma, is their perception that they have no choice in voice. And so it might be something as simple as, do you want ice in your cup or no ice, versus you need to drink something, right? Or you're just, every step of the way, consent is a continuous process. Like, I'm going to touch you with this hand right now. I'm going to use this stethoscope. I'm going to walk behind you. Does this feel okay? And a lot of times, especially children, because pleasing means safety, right? Appeasing adults means safety, is they'll say yes when they wish to say no, but they can't say no. And so I always give them the option of saying no. I'm going to do this. I need to do this thing. Is that okay with you? Or would you rather I not? You can say no. Would you like to do this? Yes or no? Like, I'm giving them the option without accidentally implying, like, I want you to say yes. And if they say no, then we can negotiate that. And I might just say, if it's a procedure I have to do, I might say, well, would it feel better if you held this end of the stethoscope and then I did this? Or would you like to look at this first before I put the stethoscope on you? Or, to the extent possible, I'm going to try to negotiate that. Why don't we put this one aside, and then we're going to do this one first, and then we'll come back to this and see how you're feeling. Right. And if somebody says, I don't want to put the paper dress on, again, to the extent possible, I want to be able to say to them, okay, we're going to perform this exam with as much clothing on as possible. We're going to figure this out and work through this so that you can feel safe.
So quick question. So I've been a nurse for a long time, 30 plus years. One of the things that we used to do, and I don't know if there's anything sound behind it, but a lot of times with not as much babies, you have I used to always have, and I was a pediatric ICU nurse. We'd have the moms hold the baby when we're doing something, but those toddler years, there were times that you'd maybe have to like papoose them or do something to get something painful done, because that was the only way you were getting it done. We often we'd have mom or dad step out. So kind of we were the bad guy, and then mom and dad were coming in to like save them. Is that like totally wrong to do?
No, it's not. What the ideal situation, I had this happen to me many years ago when my children got a bad burn on their hand, and they put them, what is it called, where they strap them down to that?
Yeah, the papoose board.
Yeah, yes. Yeah. Okay. And they asked me to leave, and I'm sure there was a good reason for that. And I knew that I absolutely needed to be calm for my child. And I said, I'm not leaving. I don't want the papoose board. I will hold my own child down. And so, but I had the understanding of, if I can stay calm and soothe my child and not freak out, they're going to let me be here with him. And that's the best thing for him. Right. So I held him down and, sung a lullaby to him, and we got through it together. And
That's
so
awesome.
that's the ideal thing, right?
Right.
Like, mom and dad can understand, you can be present if you can be calm. How can I help you be calm? Right.
And most parents can't.
Yeah. And
A lot of parents can't.
if you can't, that's okay. then we're gonna ask you to step out and we'll get this done and we'll keep your child safe and we'll have you come back in as soon as possible. But then still having, is there somebody who can sort of supplement that caregiver role where there's that warm, nurturing presence, even if they're not familiar with it, but that
Okay.
sort of warm, nurturing, soothing presence.
So ideally, it's better to keep them in the room and being calm and supporting and
That is
connected.
ideal, you know, so I have a child who had their tonsils out when they were, you know, very young, and I was so impressed with the surgical staff, and I was allowed to be in there, I was allowed to scrub in, I was allowed to actually
Wow.
come into surgery room, and when they put my child, you know, they were hooking him all up to put him to sleep, you know, they were showing him a video. They actually had their phone over him and he was watching a video of a cartoon that he was like, the whole thing was about we're happy and we're joyful and now we're going to count to 3, and he was out. So his last recollection and his last moment in his nervous system before he fell asleep was just like calm and happy, right? Because the nervous system knows that you're under threat in surgery even when you're not conscious, which is why we wake up feeling so panicky and paranoid sometimes. The nervous system has sensed that. So
Wow.
those surgery experiences, especially in the older population, when I do an intake, I'm asking about medical history because for children in the older population who were like, you were just drug in there and held down, that was very,
Wow.
very traumatic for them. We're doing so much better these days.
Yeah, I'm so glad I asked this question because I was near a nurse before I had kids. And now that I have kids, I'm like, oh my gosh, you couldn't, like wild horses couldn't keep me out of
Yeah,
there. Yeah.
exactly.
Thank you so much.
Yeah.
It looks like we've got a couple questions, Leanne, in the chat. Are there any specific trainings you have found particularly helpful in terms of trauma and helping kids regulate? And then also, how do you engage families that have older children struggling, but the household is very unstable and parents are more hands off? Or how do you get the parents to engage more?
Yeah, so some of the best like Bruce Perry's work is really good. Daniel Siegel's work is very good. It's also very clinical. So if we're looking for information that's just more for like the non-clinical layperson, how do we help children with trauma for just the general caregiver? The trust-based relational intervention protocols are excellent. And so they're at Texas Christian University has a Child Development Institute, and it's called the Karen Purvis Institute for Child Development. And you can go to their website and find free online sources, videos. They now have protocols that have been adapted for the school and for the judicial system. And the second part of that question was, can you repeat that?
How do you engage families that have older children struggling, but the household is very unstable and parents are more hands off? How do you
Yeah,
help parents engage more?
so what I want parents usually will work with first and foremost is one, routine, 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 right? Because we need a rhythm in our life, and whether the child likes it or not, they need the rhythm. The nervous system needs the rhythm, and kids will notice that they feel better when there's less chaos and there's like, we know when dinner's happening, we know when bedtime is. The other thing is sleep. We have to emphasize the importance of sleep, and people don't understand it. And we've seen this huge spike in mental health problems among adolescents that is indirectly related to to the cell phone. What's happening is they're up all night on the cell phone. So helping parents learn, how do we manage and negotiate cell phone use at nighttime so kids can sleep, and helping youth understand it too. If I've got a youth who's sleeping 3 hours a night and then they're trying to take naps during the school day, you know, I will talk to them about the importance and maybe negotiate. Do you think that you could add 2 hours to your night? Can we go to bed an hour earlier? Can we put the phone away an hour later? Can we, yeah, and once they start to shift it, they'll say, I feel better. Like I'm paying attention, I'm sleeping less. I go, okay, we got 5 hours. What you really need is 9 or 10. Can we add 2 more? Right. So we're negotiating that with them. And then connection, connection, connection. So I might work with parents to say, is there a time during the day or week? You know, the rule is 1 check-in a day with your child, with your teenager at least, and they're going to reject it. They're going to be like, don't talk to me most of the time, but we want them to be able to count on you to say, hey, I'm here to talk to you about your day. Like, how was your day? I'm happy to see you. And it's not anything about lecturing the child or pointing out their bad behaviors. It's just 5 to 15 minutes of a positive interaction once a day. And then once a week, at least once a week, can we do something as a family? So parents who are having a really hard time with intersubjectiveness, and can't do the face-to-face emotional connection, what I'll say is play a game with your child. Do something together where you're enjoying something. Throw a ball, play a game, do a board game, and cook something together, go for a walk where you're doing something. And that time is protected so that we're not talking about hard stuff. We're not, unless the child brings it up, and then the parent's job is listening, right? So we're not lecturing, we're not pointing out negative behaviors, we're not talking about things we're upset about in the past, we're not telling them what we want them to do. We are just listening and connecting.
Great. Well, thank you so much, Dr. Dakota, for that great presentation, and thanks for all of you that have joined today.
Thanks, everyone.
Have a great day.